and it's very difficult, right, to talk with your mask on board. So can I just peel it off for a while? I'm sure I'm more than 6 meters apart from you, right? And I've been vaccinated. You know how Yao did it, huh? All right. So today we took the chance to actually share with you or meet you in person so that you can ask us any question that you have in regards to COVID-19 with VC. But I thought VC plus meeting you guys in a small meeting like this so that you can ask me or ask one of the panel as the dilemma that you have in managing COVID patient in one of the wards. And you know, right, nowadays, everybody have to master COVID-19 management because COVID-19 patient is going to be everywhere in the hospital. All the other hospital will turn into hybrid already. The initial plan was some, to be turned into a center where they house the COVID-19 patient for a while like Chitra. But now apparently with the huge number of cases that we have requiring oxygen support, we have already changed every hospital, or the plan is to change every hospital to have a ward for COVID patient to manage the COVID patient, yeah, because we are too overloaded. So a glance to, if you think COVID-19 is something like flu, it's not. It's more serious than flu in terms of RO number, incubation time, hospitalization rate, and also fatality rate. Yeah, so the fatality rate is higher than patient with flu. Now, I'm sure that
Malaysia,
Yao has mentioned this, and throughout the presentation today, I'm going to mention it again and again. It's something like dengue. This is a mantra that we use in, presentation of COVID-19. Now, a lot of time when you listen to the
COVID-19 disease.
from the
Asymptomatic
IWARD
patients are
or from
categorized
the
as
KK
stage 1.
or from PKD, they will
Symptomatic
mention
without
again and again
pneumonia
CAT,
is in
CAT
stage
1,
2.
CAT 2, CAT 3, CAT
Stage
4.
3 is for
Now, it's
patients
not
with
that
simple
PID love cats so
clinical
much and we
or
don't love dogs,
radiological
but
sign
CAT
of
means a
pneumonia,
simple thing as
but without
categorizing your
requiring
patient into
oxygen.
the clinical
Stage 4 is
stages.
patient
Why
with
is it so
pneumonia
important
and
for you to do
requiring
that?
any
It's
form of
because for
oxygen
you to
therapy.
expect what are the
Stage 5
complications
is
and
patient
act
who
on the
is
complication
critically
fast
ill and
or
with
prevent the
multi-organ
patient from
involvement.
going into ICU care. All right. Okay, so in summary, there are 5 categories. Category 1, 2, 3, which are mild category. This is not the category, the staging that the Westerner or the other people outside there are using, but this is more for us. But category 1, 2, 3 means the patient is having mild COVID-19 pneumonia, and category 4 and 5 means the patient is having severe COVID-19 pneumonia infection. All right. So why is it so important for you to know the category as well as the days of illness? Because you want to predict what are the complications that the patient will come into. For example, if the patient come into you with the earlier category, like category 1, 2, or 3, or less than 1 week, it means that it's due to the replication of the viruses. So the treatment that you give is actually to prevent these viruses from replicating in one's system, right? So it's to target the virus itself. Compared to the later part, when the patient is in compared to the later stage, when the patient presents to you like after 1 week, then at this moment, the host inflammatory response will play a role. At this particular point, you may want to think that antiviral may not be so effective anymore, and therefore you may want to consider inflammatory response or using other interleukin inhibitor, for example, tocilizumab and others. All right. So you also want to know whether the patient, which category the patient belongs to, because you need to offer the appropriate intervention, because in COVID-19, everything is about the correct timing, the correct medication, and the correct referral, all right, to ICU. Okay. So I won't go into this because this graph just illustrate to you in which part you are going to offer treatment. I will dwell into it later. All right. Now we'll share with you this next slide from Ben and gang in Sungai Buloh Hospital. Basically, they look into the characteristic of the patient presented with COVID-19 pneumonia in all the hospitals that we have in Malaysia. Yeah. So what do they find? Now, obviously, they from their finding, as with other finding in other studies outside there, patient with mild presentation plays there are majority of patient who comes in with mild presentation, but pay attention to this number here, yeah, the 30, the 84, the 84, right? So it shows here that even if you present with minimal or mild illness, you can progress into severe illness. All right, that is the reason why we emphasize on certain group of patients to be admitted into the hospital or to be observed, more frequent in the ward setting. All right. Now, who are these people? They are, like, y'all have mentioned, those who belongs to the elder age group, those who are more than 70 years old. So that's the reason why we tend to admit those even with more than 70 years old to, even if they don't have symptom, to our PKRC, our low risk center. It used to be in our ward, but because we don't have space anymore, so we admit this group of patients, regardless of the symptoms sometimes, into, if they belong to the mild, disease, into PKRC or any other wards that has available space. Right. Now, the others are those, as Yao put it, those with comorbids. All right. So those with age more than 60 or those with, number of comorbids, we tend to admit them regardless of their category into PKRC for us to monitor. All right. For example, if they belong only to Cat 1 or Cat 2 mild, they just go to PKRC until they show more symptom or more improvement. As I put it, it used to be the hospital, but we don't have space anymore for this type of patient. All right. Now, I just want to mention this again because if you are in charge of I ward, you know that patient with CKD, Dr. Ching's patient, and stage renal failure, there are quite a number of them. All right. So with this study found by, this finding found by Dr. Ben, so it's not something that is a surprise, yeah. Why is this, keep on changing on me? All right. So it's not a surprise, yeah, because those with kidney disease or those with end-stage renal failure, they tend to deteriorate in, for COVID-19 pneumonia. All right. Apart from them, from that, they also come in regardless of their staging, their Cat 1 or Cat 2, because they usually are dialyzed in center. And when they are down, they are usually unable to dialyze in that particular center, so they have to come in. So if you do round in the ward, in I ward, so you will find that, sometimes end-stage renal failure need dialysis, PRN disease or something like that, and they are usually belong to category 1 or category 2 because we cannot find other space to put them in. Yeah, so be careful with this patient. Always ask them for any warning sign symptom in the ward as well. Now, apart from that, as time goes, when we are managing, COVID-19 pneumonia now, we find out that more and more young patients come in. Why? Because they are obese. So obesity, morbid obesity is one of the, poor comorbids as well. Because when they come in, they tend to come in very, very bad. Now we have 2 or 3 patients in our ICU right now being ventilated with very high SiO2 setting and all that, just because the problem they have is morbid obesity, nothing else. All right, so pay attention to those who are morbid obesity, like, those 120 kilo, 130 kilos, they tend to fare not so good compared to the rest, yeah? So this is the same finding from Ben and team, looking into, how the recovery, how many patient recovers and how many death and how many patient develop severe illnesses. So regardless of sometimes the treatment we offer, death tend to happen. And usually 6% of the total patient develop severe disease with 3.7% require ICU care, and 1.3% of the total patient will die. All right. So as time moves on, I'm sure our patients are getting more. So there will be more number in ICU and more death that happen. So compared to last time when I managed COVID-19 pneumonia, every day I don't have death. So I feel very proud and, to say that, I'm that good in managing COVID-19 pneumonia. But nowadays, every day is also a depressing day where 3 or 4 patients die. So it just shows to you that the numbers are huge and the patient tend to present late and very, very ill. And by the time they present to you, their FiO2 will be around 1 or 0.9. And that's very difficult for us to reverse on all this problem, yeah? So again, always when you do round, pay attention like dengue fever to the warning sign. I don't have to, go through it again. I'm sure we can share the slide with you later. All right, so what to review? Of course, there are sets of questions that you need to review. I can also share with you later whether the persistence of symptom, whether it's cough, fever, exertional dyspnea. All right, a lot of time they are having, happy hypoxia, where they remains happy, but their oxygen saturation are a bit low until they exert themselves or you exert them, then only you notice, this patient is having hypoxia. And when you took the ABG, sometimes the PaO2 can be as low as 70 or 60, then you'll be surprised, like that also can live, something like that. All right, so be careful. All right, so any saturation that is less than 97 or 98, be very careful. Check again the saturation monitoring, or maybe if you need to go with ABG, then you have to go with ABG. All right. Now, so there are going to be quite a number of slides. So I thought of making it easy for you, that you just pay attention to the slide with learning points so that you can bring these few learning points with you, because it's not easy to teach what we've learned within 1 year for you in 45 minutes. All right, but I have to make you be able to manage COVID within 45 minutes. All right, so the learning point number 3 is that whenever the patient present to you with different staging, then different review have to be carried out. For example, if patient present to you with clinical staging 1 and clinical CAT 2, then it's easier. You don't have to frequently monitor the patient compared to CAT 3, CAT 4, or patient critically ill who is in ICU setting. Then you have to monitor them earlier. So in this slide, it's already been shown that how frequent you need to monitor, how frequent you need to observe the vital signs, and how frequent you need to do the baseline investigation. So I don't have to dwell into this. You can share. I can share it with you later as well. All right, now the next question, I'm sure you guys are, keen to ask. Then antiviral for everybody. Do we start antiviral for everybody? Since I was seeing that, the initial 1 week is driven by the viral, right? Rather than inflammatory response phase, the host inflammatory response. So should we give antiviral even at stage 1? So there are a lot of conflicting data. The most promising antiviral against COVID-19 is remdesivir, but we don't have it available here. It's by Gilead. But a few studies, landmark studies, has been shown with regards to the, effect of remdesivir. It's not so promising, but one of the landmark study I'm going to quote to you is the Solidarity trial. The Solidarity trial is a trial where, it's a landmark trial where you remember not previously we used Calitra, we used interferon, we used hydroxychloroquine, right? So gone were the days where we used all these agents. Why? It's from this Solidarity trial. Solidarity trial shows that none of the arm shows a promising, effect, including remdesivir. All right, it's not so promising. It doesn't bring down the mortality, it doesn't bring down the ventilatory rate, and it doesn't bring down the hospitalization rate. But in one of the other trials, another landmark trial, which is the ACTT trial, shows that it gives a good effect if you were to start it on the patient who's receiving oxygen. The best is on the patient who's receiving oxygen. And the effect is actually not so good in those who doesn't receive oxygen or mechanically ventilated patient. So this is a landmark trial. Because of this trial, a lot of major guideline outside there came out with a statement. For example, IDSA guideline, what do they tell you? They tell you that if you have saturation more than 94%, don't use remdesivir. If you have less than 94%, but it doesn't require mechanical ventilation, then use antiviral or remdesivir. Similarly, like in NIH guideline, also mentioned that you use it in those who require oxygen via nasal cannula. You may want to use it in those who require ventilation, all right, because the data is not so strong. Now, we don't have remdesivir, so what are we using? We are using favipiravir. Now, a lot of my colleagues say it's so difficult to pronounce, right? Favi, whatever nonsense you're doing, right? But it's favipiravir. Why we are using this? Because it's the next available antiviral that we have that has been proven from one of the meta-analyses that it shows significant clinical and radiological improvement. So in our country, we don't have remdesivir. We have favipiravir, and what we are using is 1,800 milligram BD followed by 1,800 milligram BD. The commonest side effect that we use, we don't see frequent side effect with our patient, except a bit of raised transaminase, a bit of raised uric acid. That's about it. Interaction also not that many. It increases, theophylline increases favipiravir and pyrazinamide. Watch out, yeah, if you use it with pyrazinamide because of the effect of hyperuricemia. And there's no data with regards to eGFR of less than 30 mil, but we personally have tried that with a lower dosing, and usually it's quite safe, all right, without much side effect. Now, so learning point number 4 that I need you to bring back. From category 1 to 3, if they don't require any symptom, and if they do not have comorbid or warning sign, do not start on antiviral because the data is not strong. That's the reason why guidelines has been given out, all right? So who do you start favipiravir? We start in category 4 or 5. That means 4, remember, those pneumonia that require oxygen support, the normal nasal prong, the venti mask, but we don't use it so much in our ventilated patient. If you see patient in our ICU, they are not on favipiravir. Why? Because the data is not strong to support this. All right. Now, we also start favipiravir because we want to prevent deterioration in those clinical staging 3. Remember staging 3? What are they? They are those with pneumonia but does not require any oxygen support when they have comorbids as well as warning sign. So we tend to individualize. Now we have hope actually to start on category 2 as well in PKRC, those with obesity or those with age and more than 50 and comorbid. But as it is, our supply is not allowing us to do so. Why we are advocating this? Because in PKRC we notice, yeah, this group of patients, they come in very well. Then suddenly at night, itulah masa bila semua nak jadi mereng. Katil tak ada, they decide on us. So we thought we want to start it early in this group of patients. But as you know, favipiravir is being produced by one of factory in India. So India is locked down. So our supply tak adalah untuk orang stage 2. Maybe individualized. All right, so take home message for this slide is that you want to start on favipiravir, stage 3, stage 4 and 5, or stage 3 with comorbid or show signs of deterioration. Okay, are you with me so far or are you lost? All right. Now, the next slide will tell you when then do you suspect inflammatory response phase. So initially was a viral phase, right? So easy, right? Favipiravir only adjusted if eGFR is low, nothing else help except maybe pray and then, eat healthily and have a good, positive outlook in life, all right? But in stage 4 and 5 is a bit different where your host inflammatory response play a role. Now, how do you know this? By looking at the day of illness. Similarly, like dengue, sometimes it's difficult to know the day of illness because patient just forget. Alah, lupa lah bila they develop symptom tu. Or, they don't have symptom at all. Then you have to go with when is the COVID PCR test being positive. So when do you suspect this inflammatory phase is going on? When the patient is in day 5 to day 14, when you see the saturation dropping, when you see your CRP increasing, when you see your other inflammatory markers increasing like ferritin or D-dimer, or in our hospital setting, we are lucky we have interleukin 6, all right? Or if you see the X-ray worsens, compare later, I will show you a few X-ray. Initial X-ray was not too bad. Second X-ray was very bad. All right. So these are the markers that show to you, that may suggest to you, hey, look here, this patient is going into inflammatory response phase, and I might be dealing with trouble here. So you may have to dwell in and pay more attention to this patient, or give oxygen supply adequately, or refer to ICU if you need to, yeah? All right, so what do you use in patient with in inflammatory phase? The only drug we have that has been proven from the trial is the dexamethasone. This is a landmark study showing the positive usage of dexamethasone in those with COVID-19 pneumonia. But this is a multi-center trial, is a randomized control trial in which it looks at, metoprolol compared to the standard care, and it find out that dexamethasone helps in those with COVID-19 pneumonia when they are in inflammatory phase, when they require oxygen support and intubation. That is the reason why you don't see us simply banging everybody with COVID-19 pneumonia with dexamethasone, right? So the moment the patient is having, hypoxia, depending on the oxygen, even though it's a prong, 3 liter, 4 liter, we give dexamethasone 6 milligram OD based on this recovery trial. All right? Are you with me so far? Okay. So next, I will illustrate to you one case here, how we use DEXA. Now, 58-year-old diabetic hypertension presented on day 9 of illness. This is during the inflammatory phase. How do you know that? Other than that, supported by ALC, absolute lymphocyte count 0.4, anything below 1 is not good. LDH of 240, neutrophil lymphocyte ratio is more than 3. Anything above 3 is not good. And chest X-ray, obviously, if anybody works in COVID ward before, they know that this is a typical X-ray that you see. Once you see, you will never forget it, and it will haunt you forever and ever. All right, as if everybody's X-ray is supposed to be like this. All right. So initially, when the patient present into the hospital, the CRP was 24, climbing up to 48 because requiring oxygen. They start on dexamethasone, and on day 12, CRP goes higher. Then they push up the dexamethasone 6 milligram to BD. Remember, I told you recovery trial shows that, DEXA is only of 6 milligram OD, but in those who's not responding, you may want to push the dexamethasone to 6 milligram BD. So look into your inflammatory markers, look into the oxygen support, and you feel the patient is not doing well, the chest X-ray is worsening, just push up to 6 milligram PD. That one, you don't have to have ID permission to do that. We are giving you the right to decide because we are tired to decide. All right. So in fact, up to total 12 milligram was given. And if you look at it subsequently, the oxygen came off and they are able to wean off the oxygen by day 5. And the dexamethasone was tapered down and stopped at day 10. All right. Now, learning point number 7, when do we use dexamethasone? It has to be at the right time, right dose, and right patient. It cannot be all patients you start on DEXA. If you start on day category 1 or day 2 or day 3, then it's going to prolong the clearance of the viral and the infection will be longer. All right. So you need to hit it during the inflammatory phase, which is around 5 to 14 days, and where it's supported by other parameters like your inflammatory markers. And usually this patient requiring oxygen. Total usage of DEXA in the recovery trial is 10 days. So you may want to wean off if the patient wean down the DEXA within 10 days, if you are able to wean off the oxygen easily. Some patients, you are not able to wean off the oxygen easily. Those who goes up to high flow mask, those mechanical intubation and all that. And with this, you may want to prolong more than 10 days. All right. Titration done if there is improvement of clinical features, oxygen requirement, and inflammatory markers. So you, again, is like every day's work in medical ward. Look at the patient, look at the oxygenation, look at the vital sign, look at your blood investigation, and make a stand. You have to make a daring stand where this patient belongs to and start acting on it. Are you with me so far? Okay. All right, case number 2. Now, this is a 57-year-old diabetic lady. Of course, the risk factor is history of, left breast cancer, chemotherapy done, and presented on day 7 of illness as COVID positive, requiring nisoprong 3 liter on admission, clinical category 4. So we are talking about all these patients who's requiring oxygen. Given dexamethasone, IV 8 milligram on day 1 admission, favipiravir, Clexane, desaturate further to require face mask 5 liter per minute within 24 hours. All right. So if you have a look at day 5, the patient was on Dexa, but suddenly on day 8, where the oxygen requirement is increasing trend, they push up to methylpred 150 milligram OD, and subsequently on the 9th, they push back to Dexa. All right. So when the patient starts to improve, then they taper down the dosing of Dexa and then starts to wean off. All right. So now some of you ask me, this is not a very famous question for us to answer because we don't like answering it. There's not so much of data that support it, but in those after 8 or 6 milligram BD, if the patient worsen and require ICU admission or from oxygen 6 liter to high flow mask to NIV to high flow nasal cannula, we change the dexamethasone to methylpred. This is based on a few studies outside there, which shows that, for example, this study in Iran, which shows that when they enroll patient into 2 arm of methylpred, 2 milligram per kilogram OD, and dexamethasone of 6 milligram OD, they find out that there's different in clinical status, better in the group with methylpred, and the hospital stay was shorter, and the need for ventilation is lower. All right. So that's the reason why, ladies and gentlemen, when a patient deteriorates further with Dexa of 6 milligram BD, we sometimes change to methylprednisolone. But the dose we use now are usually like 2 milligram per kilogram. All right. You guys with me so far? Okay. So learning point number 8. What if Dexa does not work? So you increase the dose of Dexa to 6 milligram BD or 8 milligram BD. Still not working, then you change to methylpred, 2 milligram per kilogram OD. Why methylpred? Number 1, because of those small observational data. Number 2, there are more experience treating ARDS with methylpred compared to Dexa, and it achieved apparently in one study a higher pulmonary level compared to dexamethasone. So I suppose even in the big guideline like NIH, NIS, they recommended that you change Dexa to methylpred if the patient requiring and increasing oxygen support. All right. The next slide is just to show to you the dose that we usually use. Dexa is 6 milligram OD. It's equals to methylpred of 0.5 milligram per kilogram per weight. So if you use 1 milligram, like me, I'm 60 OD, then it's equals to 6 BD already of Dexa. All right. So that's the reason why when we want to taper off methylpred with 2 milligram, we cannot taper to Dexa, head to head because it's too high dose. Only with 1 milligram, then we can cut down to Dexa. Now, why we are cutting a lot of patients that respond to Dexa? Number 1 is because it's been proven. Number 2 is because we are running very low stock in methylpred. Would you believe it in your life that, last time when you were doing medical, siapa lah yang nak guna methylpred 500 ya? Dan ni kita guna sampai habis methylpred. Tak ada stok. Nak beli pun tak ada. So kita kena simpan methylpred kita, curi, sembunyi sebab semua orang guna methylpred. Alright, so that's the reason why we want to change fast. Alright, so if you want to change, it usually is 1 milligram of methylpred per kilogram below. Nothing above that because it's very difficult to change. It's a higher dosing. Alright, duration of exercise, I put it 10 to 14 if you are able to taper down the oxygen very fast. But in those requiring high oxygen support, like those high flow masks, NIV, those intubated, it's very, very difficult to bring them off oxygen. All right. If you do a CTPA, you don't have to do CTPA in everybody, but if you do a CTPA, you can see changes suggestive of organizing pneumonia. So that's a complication of COVID-19 pneumonia, whereby you cannot taper down the oxygen very fast. And in this group of patients, you may want to prolong the steroid in the tapering manner, but you may want to consider discussing with our chest physician as well to how long they want to continue their steroid. Usually, the way how I see them doing it, they like to maintain the steroid like 4 to 6 weeks or something like that. All right, and only wean off slowly as an outpatient later on. So they change to prednisolone and then discharge the patient, get the patient to see them back, and things like that. All right. So I'm just going to tell you in certain scenario, you cannot taper down the steroid because the oxygen requirement is still high. So in this scenario, you may want to opt for a CT-PA to just rule out organizing pneumonia. All right. I don't have to dwell further into this. Those who's managing COVID, they will know this because this is like a mantra in COVID. Everybody you see now is having what? Traction bronchiectasis, consolidation, reticular, and the worst part is the MO will tell you, doctor got GGO lah. So I say, oh, GIO or what? Then it's actually ground glass appearance. GGO is ground glass appearance. The first changes of COVID-19 pneumonia that you see. All right. So everybody with COVID-19 pneumonia, if they are stage 3 and above, they will have GGO. So GGO stand for ground glass appearance. If you can't remember anything, you remember that. So case 3. All right, if you have already changed to metapred 2 milligram per kilogram OD, and still you find out the patient in the ward, because some of the patient can still be in I ward, that's why I'm telling you this, or in the center from the district hospital or Kulim or wherever that we are opening like Jitra, and you find out that tak turun-turun makin teruk nampaknya. So what else can you offer? All right. For example, this third case, I'm going to illustrate to you. 71 years old Malay gentleman, underlying IHD, hypertension, diabetic, and dyslipidemia, presented on day 6 of illness with cough, fever, and myalgia. Desaturated on admission on day 6 of illness, SpO2 on room air 92%, on nisoprong 93 to 94%, escalated to 5 liter, and COVID PCR is positive. Now, if you have a look at it, the CRP was high, 219. So started on Dexa, Favipiravir, Clexane. No issue there, right? So initial management. Then subsequently increasing oxygenation, push up, then change to metopred. Correct, right? Like what I've told you. All right. So in spite of that, chest X-ray repeated on third day is still worsening. What else can we offer? And this is a time, ladies and gentlemen, for you to pick up the phone and give us a call. Because we have other medication, but we need to know who to give because the complication of giving it is huge as well. All right, so we have tocilizumab, or sometimes so this is a chest X-ray that has worsened. All right, why tocilizumab? Tocilizumab is usually being used by the rheumato people, right, as well. So we don't use it frequently. Before COVID-19 pneumonia, I just don't know what tocilizumab is all about. But after this, I have got to read through and find out what is tocilizumab. So I become quite okay with that. Now, why the usage of tocilizumab? This is a landmark study, REMACAP trial, which shows that if you start on adding toci on top of your metopred, not for every patient, for patients who require ventilatory support, NIV, high flow nasal cannula, 50%, 50 liter and above. So this is not being used for those young in lower end, like, ventimask, even high flow and all that. So it shows that the mortality rate is higher and the time spent in ICU is also lower. So usually you can refer to us, then we can discuss on that. So some interim position statement with regards to tocilizumab with a big guideline outside there. I don't have to go and dwell with you further. So suffice to say, learning point number 9, if you have patient that still deteriorate to you on board with your metopred of 2 milligram per kilogram, please pick up the phone. By all means, please discuss with us. Then we may, by then usually patient will be under our care. We will give a interleukin-6 inhibitor, or sometime worst come to worst. Would you believe it? We run out of tocilizumab now also. So we are giving pulse metopred, which maybe the study is not so strong there, but that's the only thing that we have. Have you ever been in a position where every day you look at the patient? We have actually the list of patients to go up and to go out. All right. Some of the patients, in spite of what you're doing, the FiO2 is 1, APR mode 0.8, 0.9 is depressing. All right. So So sometimes we don't know what to do. So we use all those studies small in those, ARVS. Then we give curi-curi, give a bit of pulse metal prep. But you need to know how to give it and when to give it, because the effect of pulse metal prep sometimes give rise to, sepsis and all that. All right. So please do discuss with us. Are we clear on this? Or are you lost already? It's okay, after this session for you to have more questions. I've been having that question until now. So what do I give after this? And what am I supposed to see? Why is the CRP not raised? Why is the interleukin 6 single digit? It's always been like that. So it's normal, because as you go along, you notice that, tak sure lah, nak kena tanya, then please do ask us, all right? Okay, so learning point number 10, as with other medical patients in the ward, whenever the patient be sad or turn ill, always go back to your clinical assessment and ask yourself. There are 3 things that you must ask. Number 1 is the patient worsened because of the inflammatory response of the host or cytokine storm. So with that, you may want to consider looking into and repeat the inflammatory markers as well as the X-ray. The CRP will go up high. In our setting, we have interleukin 6 to help us. Or is the patient suddenly breathless because of your pulmonary embolism? Remember, Yao was saying that the incidence of pulmonary embolism is very, very high in COVID-19 pneumonia, regardless of them being on prophylactic thromboembolic, therapy. All right. Or worse come to worse in ICU setting, is your patient worsened because of bacterial infection? So with that, you have to use your clinical skill to assess the patient. If you feel that the patient is worsening because of secondary bacterial infection, total white going up high, and maybe supported by Procel if you have, then you may want to upgrade the antibiotic. All right? So it goes with what you think the patient is having. If you think the patient is having inflammatory response, overdriving, then you look into the ferritin is going to go high, the CRP is going to go high, but total white single digit saja, 7, 8. And that's when the cytokine storm is worsening. All right, so you may want to upgrade your steroid or change your metal pred or add into C or pulse metal pred or whatever you have. All right, are you with me so far? Or if you think the patient is having pulmonary embolism, then do CPA lah. Now, to rule out that out, then you may want to cover with a BD dosing of Clexane, yeah? All right. Now, I don't have to dwell with you into this further because Yao has already shown to you a study in China showing that the rate of thromboembolic phenomena is very, very high. In fact, it's not high in arterial, it's also high in venous. All right, if you look into this study, this is a landmark study, one of the study in New York, in the hospital in New York, where they show that in patient who is all in ICU and non-ICU, the risk of thrombotic event is around 16%. Of course, the risk is going to be higher if you are in ICU. And true enough, quite a number of times when we did CTPA, patient is hypoxia or ventilatory setting goes up, we can see pulmonary embolism there in spite of our OD Clexane or BD Clexane. All right, so pay attention to this, yeah? So remember, thinking about pulmonary embolism, if there is a marked increasing of the D-dimer, if there is a worsening of hypoxemia, blood pressure, tachycardia, and X-ray finding is not suggestive of worsening of, that GGO or whatever that they saw, all right? Or if you have a new evidence of acute unexplained right heart strain or intracardiac thrombus, or you have clotting vascular devices. So in this group of patients, remember, please arrange for CTPA. Nowadays, I'm sure the radiologists, the radio gang has already been supporting us from day one of COVID-19 pneumonia. They never rejected our request for CTPA, especially if we said to rule out, pulmonary embolism in a patient with COVID-19 pneumonia. It's just that you got to plan, you got to make it to be staggered. Unless and until you can rule out pulmonary embolism, if there is no contraindication, then you push up your Clexane to a treatment dose first. All right, are you with me so far? Okay, so with that high frequency of pulmonary embolism, now what we are doing is that in those with, admitted requiring supplemental oxygen, we give them very low dose of enoxaparin, 30 to 40 milligram OD. Now, if they are, in ICU setting, they go higher because remember of that landmark trial that says that they go into pulmonary embolism regardless of your normal dosing of prophylaxis, so you go higher. There is no bleeding tendency. Of course, full dose if you think and it's been confirmed there is a evidence of pulmonary embolism. All right. Now, my last slide. I've already told you when to start favipiravir. I've already told you when to start Dexa, when to change to methotrexate, when to refer to ID. I've also dwelled into when to start on, anti-thrombosis, right? The last slide is on secondary bacterial infection. Now, initially, I do not want to address this, but I felt like, I've got to address it to a certain issue because I'm sure a lot of you will ask, bagi steroid sini sana, kiri kanan, atas bawah, infection tak higher ke? Or do we have to, start on high-five antibiotic? Like patient datang, COVID-19 pneumonia, Cat4, Pip-Tazo, mampus lah kita. But we know that secondary bacterial infection can occur. It's quite high incident in ICU setting, all right? More so with all those steroids. So we are making it available to all the district hospital to use these three antibiotics: Augmentin, Ceftriaxone, Pip-Tazo. All right, the rest you may have to discuss with us. By then, the patient will come to us already. All right, so these three antibiotics are going to be available in all district hospital. So we do not want, including subacute Clexane, including pantoprazole, Dato. So all these favipiravir will be available so that all of us can help to take care of our COVID-19 patient, COVID-19 pneumonia patient. All right, so then come to a question. Do I start on normal antibiotic? Do I cover antibiotic? When you say viral, then maybe it's viral, it's not bacteria. But certain condition you are not sure. Toto White pun dalam 15, 16, you're not sure. Just start on some antibiotic that can cover community-acquired pneumonia. For example, Augmentin cukup lah. Tak payah Pip-Tazo sebab apa? Pip-Tazo sebab I nak start Dexa lah lepas ni. Tak payah. Nah, start Augmentin. If the patient doesn't have any evidence of secondary bacterial infection, then you can wind down Augmentin and take it off, after a few days. All right. So secondary bacterial infection has been shown occur in a high frequency last time when we were dealing with H1N1 pneumonia. All right. Memang banyak. Staph dengan strep memang banyak. Tapi to our observation, especially those in I ward, when they start on Dexa, and if the patient does not require ventilation, and ICU admission, jarang-jarang lah berlaku, even when they give pulse steroid. The one that we have, so I can put to you a few meta-analysis showing a few studies. For example, this meta-analysis looking into 3,338 COVID-19 patients, include 24 study. Look at the co-infection secondary bacteria on admission. Alamak, 3.5%. Tapi secondary bacterial infection after presentation, maybe ke ICU, campur and all that, 14.3%. And this lead to overprescription of antibiotic of 71.8%. So memang sekarang ni our antibiotic memang kelang kabut. More so with patient in ICU, right? So another study shows only 3.5%. And if you have Procel that is less than 0.1, then it's less likely to be infection. But I don't have to dwell with you regarding Procel because usually ID is the one who's using it. Okay, so now showing to you some of the risk factors that can promote or increase frequency of bacterial infection. So we see it normally in patients with ventilatory support or respiratory failure, severe lymphopenia, and early ICU treatment. All right. So the group of patients that we are seeing secondary bacterial infection more commonly are the one in ICU. In ICU, memang we are facing a lot of trouble with secondary bacterial infection. So every day we've got to go in, okay, which bug is this? What is going on? And things like that. All right, now with pulse methotrexate in certain countries like India, it has shown that mold fungal infection frequency is higher. So be very careful here. So that's the reason why I tell you, want to use pulse methotrexate, yes, please discuss is the correct dosing, correct timing, and correct monitoring. All right. So the last learning point that I'm going to leave you with, secondary bacterial infection has a low incidence generally in COVID-19 pneumonia. You consider it when the risk factor is high, like when the patient is staying in the ICU, and it leads to overprescription of antibiotic or antibiotic stewardship is needed. Then you may escalate antibiotic if you feel that the infection, there is no more evidence of secondary bacterial infection. Now, I'm not saying to you that you can't use Pip-Tazo or you can't use Ceftriaxone. We are using a lot of ceftriaxone in I ward as well. So you feel that you need to cover, please escalate. And then please do a proper culture before you escalate. And then once you're okay, then you can de-escalate the antibiotic as needed. All right, I'm giving you the right to do what you need to do. Okay, so this is my last learning point. So 12 learning points for you to bring back with and to make you a better manager of COVID-19 pneumonia. All right, any questions so far? Yeah. See, God maybe still love us. Unlike influenza, influenza love pregnant ladies. All right, but unlike influenza, COVID-19 jaranglah menyebabkan problem in patient with who's pregnant. Those you are seeing, I'm sure you're asking this because you're seeing a few requiring oxygen in 2A. All right, yeah, dah mula dah lah. Sebab of this late presentation and all that. There's basically not so much of different, but you may have favipiravir has been known to have a teratogenic effect, but whatever it is, regardless, maybe you have to see the timing. And usually, sometimes we go without favipiravir if we think it's a problem, because as to us, favipiravir is a very weak antiviral. So we can go without. It's just monitor and monitor and monitor closely, but you need to know your inflammatory markers is going to go haywire. Your neutrophil is going to go a bit up, something like that. And your CRP also may be going to be up, things like that. So you may want to take everything into consideration when you are dealing with pregnant lady. But I think overall, it's almost the same. But be careful when you deliver steroid and all that. I'm sure the diabetic part, our endocrinologist has been taken care. So maybe you got to monitor regularly and, give a bit of, in helping those with insulin and things like that. So generally, it's almost the same. But we are very lucky to say that until now, we never have a very bad COVID-19 pneumonia with pregnant lady. I think God still loves us. All right? Any more question? Sekarang memang tak ada question, but later when you go through managing, helping to round in I ward or in other wards with COVID-19 pneumonia, I'm sure you may have a lot of question. So don't worry, our MO who has been helping us out, our physician who's been helping us out, they are more than adequate to help you and to make decision on things. All right, or you may call us personally and ask us. All right, with that, can I just pass over to the next presenter? Thank you. Yeah. Yeah, 1, 2, 3, 4, 5. Yeah. Yeah, that's what the study shows. Yeah. Right. I'm sure I will get that kind of question. It's been a bit complicating, yeah. Telling you that the first week is due to the viral effect, and then giving you data that is not supporting CAT1, usage of antiviral with CAT1, nor CAT2, right? CAT3 also, diorang tak tunjuk, but they suggested very high. If you look into the one of the study, the thing, can you open back the study?
Okay.
Yeah. I want to share with you this graph, which I think is more important. A lot of time, yes, we tell you that, is a viral effect. Similarly, like influenza, you don't start Tamiflu in those who's not symptomatic, right? In fact, you don't start it. You only start it in those symptomatic if they are high risk, if they don't have pneumonia, like pregnant lady. I think that goes with our COVID-19 pneumonia, with our favipiravir as well. Now, why we are not using it in those with Cat 1 and Cat 2 is because of this study, this ACTT US NIH study, which shows that it cut across the placebo in those not receiving oxygen. All right, the best effect will be at this group, those receiving oxygen, but not so good data in those when mechanically ventilated. Now, you were asking me whether is it because of this graph that I'm showing to you, right? Okay, you memang tak puas hati dengan I tau. Tahu memang. You kat mana dah lah ni? Kat medical slide number 16 lah ni. Okay. So dia tak puas hati sebab kat sini I tunjuk kat dia viral responsive phase ni is winning off, right? Is that what you're asking? And then why am I using at Cat 3 and Cat 4? Alright, I know, but even it's winning off, but there's still some effect here. Alright, and even if I say the host inflammatory response is beginning, but it's not necessarily, it means it's high, it's coming towards it. So maybe there's an overlapping thing. I know that, generally, if you ask me, memang it should be here. That's why I'm telling you kan. Kalau banyak viral kat sini lah. But as you put it, macam ni lah adik. Dalam kehidupan tidak semestinya apa yang you nak, you akan dapat at the end of the day. Is that bad for me to tell you? The studies are not proving that. In fact, studies of remdesivir itu pun conflicting data. But what do we have? We only have favipiravir here. So according to what we have and according to the study, the landmark study, so this is what we are telling you. Now we know that some patients do deteriorate very fast. So we are advocating Cat 3 also without requiring oxygen. Please start using it. And then we know also in our cohort of patient in PKRC, those with Cat 2, they deteriorate. Pagi masuk Cat 2, petang masuk Cat 4. So guna juga. We are going to open it up, but I don't know whether we are going to make it official, maybe case-to-case basis. Alright? Untuk memuaskan hati awak lah. Sebab awak kata kenapa tak mau guna awal-awal. Maybe some will go longer, some will go longer. So, but the data is not supporting the usage of favipiravir in stage 1 or stage 2. All right? Any more question? I hope I please you. Or you're not pleased. It's okay. A lot of people are not pleased with me recently. Yang tu memang shock saya nak jawab. Dalam hidup, memanglah itu yang kita present. But we give you a timeline. Day 5 until day 14, remember the inflammatory response. Similarly, like in dengue, kita kata apa? Day berapa dia? Day 3. Day 3 onwards in day 7, warning sign. But some can be up to 10 days. So ada pengecualian dia. Jadi, gunalah apa yang you ada, apa yang you tengok dalam patient, day of illness, and supported by your inflammatory markers as well. Then you plan out where the patient belong to. And sometimes I'm going to tell you it's very, very difficult because our Kedahan tanya makcik, bila makcik penat, tak tahulah. Bila makcik demam, tak tahulah. Semua dia tak tahu. Habis kalau dia tak tahu, siapa yang nak tahu? Doktor lah yang tahu. So with that, we go with day from PCR. Alright? So it's very, how do I put it? Is very difficult sometimes. We cannot point out to you, memang adik, within 1 week ni memang viral response phase. Tak boleh. In real life, it doesn't happen like that. Alright, but generally, this is what we see lah. Okay, are you happy with me or still not? Alright, thank you very much.
We got question from SP lah. But this one is actually pertaining to DEXA dose. Maybe we can have our endo expert here lah. So they were wondering lah, in terms of body weight, if you are taking 0.5 mg per kg, is equivalent to 6 mg OD DEXA lah. So they are wondering if patient is obese, is there any difference in DEXA dosage?
We've been asking this ourselves because if you look into the study of recovery, regardless of whatever, they're giving 6 milligram OD. So question now to our endo, does it matter or not? With the body weight, because a lot of our patient mancing in ICU, 150 lah you, 180. Nadia and I look at each other, berapa ya Nadia? 8 kot, 8. So we just give whatever we think that needs to be given. So is there any requirement to push up the dosage according to body weight? Can we have some opinion from, endo people ka? For us, we don't know. The maximum we go is like 8 milligram BD, right, for DEXA. Tapi metal prep, yes, we follow the weight.
8 mg.
DEXA kita tak berani, takut. 8 milligram BD saja. But with metal prep, we go with weight. 2 milligram per kilogram, kalau you 150, just imagine berapa banyak kita bantai dah 300 you. Takut. Sebab tu, if you go into IWAD, we may need our endo near help after this. IWAD is full of DXC that goes haywire like nothing. It's because part and parcel Sharifah and Nadia lah. Apart from suppressing the immune system, we also make the diabetic control haywire. Alright, so any input from the endo, Shatia? Or any other endocrinologist, Shabinas, how? Can you help us out? What would you recommend? So we use with 8 milligram BD, that's the most. Apart from all of you here, we are also airing this to others in the state, yeah, so that we are making it as a a guideline for everybody to follow. I may have a different stupid explanation. I don't know whether you call it stupid or not from ID. DEXA is a high acting steroid, right? So it lasts longer in the body. Maybe we just 8 milligram BD compared to metopred is intermediate acting. All right, so the effect of inflammatory, of course, is lower lah. All right, so maybe that's a stupid explanation. I don't know. But as far as I'm concerned, with regards to the study, they use only 6 milligram OD of DEXA. So if you need to push up to 6 or 8, if 8 we use in high end, high big size patient, we never go more than 8 because there's no data to support that. With metopred, the data is supporting 2 milligram per kilogram. So regardless, sometimes 2 milligram can be like 300. All right. So that's what we are following. So I hope the Sungai Petani people will be okay with the explanation. If not, maybe we can discuss on that later. Mohon penerangan menggunakan
dari audience menggunakan mic presenter.
Rosak lah you, rosak. Okay, any more? Okay, all right, no more so far. So I'm done, I think. All right.